Hello, I'm Dr. Vahid Behravan. I'm a neurologist with TeleSpecialists, and today I am joined by two of my esteemed colleagues, Dr. Jessica Floyd and Dr. Theresa Sevilis. Dr. Floyd is a neurologist and fellowship trained in clinical neurophysiology, and Dr. Sevilis is a neurologist and fellowship trained in vascular neurology. Both doctors have extensive experience in telemedicine and teleneurology in particular. We will start with Dr. Floyd. I want to ask you about this. We are learning more and more every day about the signs and symptoms of this novel coronavirus infection, but in your experience and review of literature, what are the neurological manifestations of COVID-19?
Very good question. So we are learning more and more about the neurologic manifestations of COVID-19 as the days, weeks, and months go on. Neurologic manifestations of viruses is not something new, and I think every neurologist can agree on that. But when we're looking at literature coming from overseas, as well as this wave going through our country of what we're seeing coming into our hospitals, we're seeing quite a broad spectrum of presentations. So we're getting consulted on patients either with respiratory complaints who then develop neurologic symptoms while in the hospital, such as seizures, altered mental status, stroke, even more peripheral nerve type of pathology, such as Guillain-Barré or AIDP type of picture. But then we're also seeing a subset that's actually coming in without respiratory complaints and more generalized neurologic manifestations. So presenting with cranial nerve 6 palsies, presenting with stroke, presenting with altered mental status, and no respiratory complaints. And then for whatever reason, either reporting exposure to a COVID-19 positive person in their family or in their social circle, or a routine chest x-ray showing signs. For whatever reason, then they're getting tested for COVID-19 and that's coming up as positive. And so we're kind of baffled in some cases as to which patients we should be testing. Obviously, we're all aware that there's different criteria in different hospitals for which patients are being tested for COVID-19, and even the tests that we're using across the country varies in terms of getting tests back within hours versus waiting 5 to 7 days. So even in some patients that we are suspecting COVID-19, we're having to wait quite a few days to really find out if they're positive. And that also has led to some delays in presentation of neurologic symptoms for when they're waiting to consult neurology. That's actually a benefit for teleneurology because they're able to have a neurologist, a board certified neurologist right there in the room, rolled in with the person that's already donned in PPE. We can get a good exam and talk with the physicians on site about the case and how to work up the neurologic manifestations this patient is presenting with in this current setting, where in not every hospital do we have MRIs, or other technology imaging types of things that we would typically be doing in a patient that's being isolated. We're not jumping to those certain procedures or imaging techniques for fear of exposing other patients in the hospital. So we're having to get creative on a lot of these neurologic manifestations and really trust our exam and work with our doctors there locally to kind of come up with a good game plan until that testing comes back and we're able to continue our workup just as we would prior to the pandemic. So we're seeing a very broad spectrum of disease. I think we're going to be seeing a whole lot more of case studies and certain hospitals kind of seeing different presentations coming up. And it's also something I think that as neurologists we're going to have to keep our eye on, even as this wave and peak incidence of cases is coming, because this is probably going to be something that we need to keep our eye on in our patients as they're presenting with different neurologic complaints down the road. So I don't think this is going anywhere from the neurologic manifestation side.
Thank you. Dr. Sevilis, since COVID-19 pandemic was announced, has there been any changes in how the code stroke is conducted?
Unfortunately, our code strokes are very impacted by COVID. The biggest concern is everyone's safety, both the patients that are coming into our hospital as well as the hospital staff. Code strokes are run as a very well-oiled machine in most hospitals and a very time-sensitive one. So now having to throw this curveball of having minimal amount of people in the room where we're used to all kind of swarming in and everybody acting at once, we have to work with less staff in some situations, the initial screening steps, potentially stabilizing them more from a respiratory standpoint than we're used to, although that does happen regularly sometimes as well. Having the appropriate PPE on, making sure that the patients have their masks on. And another large limiting factor is that families aren't coming into most hospitals anymore to try to limit their exposure. So our ability to get the history we need to treat patients in a timely manner is another challenge. And it's a challenge that a lot of hospitals across the country are facing in different ways, depending on what services you have reduced staff on, or what situation your individual hospital is in, is how that protocol is required to change in order to still be able to get timely treatment to all these patients.
So has there been any literature on incidence of stroke in COVID-19?
So there is one small study that came from China, since they've kind of had the most exposure, the longest term exposure to this disease. They were able to get one study, a little over 200 people published, that was showing about 5.7% of people had strokes with COVID, and they did show associations with patients that were having more severe cases of COVID, as well as their median day was around day 10 after getting sick. So most of those patients were not showing it as the presenting symptom. Now, this is only one small study that did not go through rigorous peer review or the typical channels of publication. Therefore, we do have to realize its limitations, and that there is a lot more information we need to gain to really know the true relationship between stroke and COVID, as there's a lot of different things that people are reporting case-wise, such as endocarditis and hypercoagulability with very large clot burdens. The opposite end of the spectrum is there's also been associations in hematologic literature with thrombocytopenia, and that leads to increased risk of hemorrhage, and also has to be taken into account, as well as the patients that are presenting with hemorrhage and not ischemic stroke. And there's also, with prior coronaviruses, there's been reports of vasculopathy, which I haven't heard direct cases with this particular virus, but we do know that's something to be keeping an eye on too. So I think there is a lot that we need to think about with each one of these patients with suspected COVID or confirmed COVID, in making our medical decisions as to what's right for that particular patient. As at this point in time, we don't know a true mechanism of this virus to stroke, but we do certainly see some associations and potential risks for them.
Oh, very interesting. So as we heard, infectious pandemics like COVID-19 create a challenge for patients and their healthcare providers, and telemedicine has become an increasingly valuable tool in providing medical care for patients in need. At the end, I wanted to thank Dr. Floyd and Dr. Sevilis for joining me today and sharing their expertise and experience. I also wanted to thank other colleagues and staff at TeleSpecialists who are doing their best in these tough times to provide the highest quality of care possible for our patients. Stay safe and stay well.